Hello, and thank you for viewing this symposium moderated by Dr. Craig Walker. Dr. Walker is the founder and medical director of the Cardiovascular Institute of the South, one of North America's largest cardiology practices. Dr. Walker serves as chairman of New Cardiovascular Horizons Conference, held annually in New Orleans, Louisiana. He is a clinical professor of medicine at Tulane University School of Medicine and the LSU School of Medicine. Dr. Walker is a clinical editor for vascular disease management and has published hundreds of articles and over 30 book chapters. Dr. Walker?
Thank you, Jonathan, and thank you, Asahi, for sponsoring this series of case presentations on wire crossing in difficult cases. I'm very pleased to be joined by two very prominent physicians in this field. Dr. Chris Lasar of the Vascular Institute of Chattanooga in Chattanooga, Tennessee. He's a board certified by the American Board of Surgery and a fellow of the American College of Surgeons. He's a vascular surgeon specializing in endovascular techniques in both the inpatient and outpatient settings. Dr. Lasar has been a pioneer in the vascular community, but a thought leader in the OBL arena, pushing the limits with technology and best practice options while delivering the best of care. He has a reputation for being a thought leader with a passion for education and developing and creating what will be seen as the future in best practices for physician-owned practices. I'm also joined by Dr. Brett Weichman. Dr. Weichman is a vascular, and he's with the Vascular and Interventional Physicians Group in Gainesville, Florida. Dr. Weichman has been in private practice for 18 years with vascular and interventional physicians with a particular interest in peripheral arterial disease, abdominal aortic aneurysms, and carotid intervention. He has been elected a fellow in 3 different medical associations, including the Society of Interventional Radiology, the Society of Vascular Medicine, and the American Heart Association. He has given over 100 invited lectures and has been principal investigator in numerous clinical trials in peripheral arterial intervention, carotid stenting, medical therapy for PAD, and stem cell therapy for critical limb ischemia. The practice has numerous interventional radiologists and has been involved with the treatment of arterial and venous disorders for numerous years, both hospital-based and at their office-based lab, which opened in 2006. I'm very pleased to be joined by these two luminaries. I will start this session with a case presentation of a very difficult case that was referred to me. This was a 74-year-old female who had presented with multiple infected wounds of a foot and ischemic ulceration. The patient had 3 prior failed interventional attempts, and on this ipsilateral leg had repair of a femoral artery for pseudoaneurysm. This was repaired surgically. The prior interventionists had tried to open this vessel, and all 3 cases had gone subintimally and had been unable to cross the areas of total occlusion. So as we look at the angiogram on the left panel, we can see that the proximal superficial femoral is patent. We can see in the middle panel, there's occlusion of the popliteal in the P1 segment here. And we can see on the right, very faint filling distally. Further, as we delayed and took delayed images, we could see that the perineal is patent and it fills a diffusely diseased posterior tibial and anterior tibial. So I decided in this case to use a Xi'an black wire. This wire has it's hydrophilic tip, it has great support, and I can prolapse and make a very, very small knuckle with this wire. And upon pulling the wire back, I can get rid of the prolapse. So I simply knuckled through the popliteal artery. It went through that very easily. I then removed the knuckle and steered, as you can see in the middle panel, into the posterior tibial, which was really my target vessel based on the angiosomes. Then you can see I re-knuckled this wire, and this wire then very easily crossed across this long segment total occlusion in the posterior tibial, entering into the posterior tibial in the foot. Next, I performed laser atherectomy on the totally occluded popliteal and the proximal tibioperineal trunk and performed balloon angioplasty, establishing flow into this vessel. I then had initially brought a balloon down and we ballooned the proximal posterior tibial. We can see I then brought a support catheter down because I wanted to exchange back out for a softer wire distally. And so I'm going to come down here. We've crossed, and now we're going to take an angiogram distally. We can see that we're now filling the posterior tibial, but there's branch disease, disease involving both the origins of the posterior lateral and the posterior medial branches, as the lateral plantar and the medial plantar branches. So I used this larger catheter so that I could double wire, as shown here on the left, following which balloon angioplasty was performed, establishing flow. And then I was able to direct a second guide wire. Now, the second guide wire that I used was a Xi'an black. Since I was having to work contralateral, I wanted a wire that had great steerability. And the Xi'an black has a twist wire, it has Act 1 technology, and it has spectacular torquing capabilities. This is a wire I like to use to negotiate pedal loops. And here I've used a Corsair probe behind this wire. Now, it was very obvious as I pushed this, this was a 150 centimeter catheter, that I would not be able to cross the entirety of this anterior tibial. So we can see here, I did cross with a wire. I then used another Xi'an black wire. I was able to steer back, joining my other guide wire. This crossed quite easily. We performed kissing balloons involving the tibioperineal trunk and popliteal. And then this allowed me to preserve the origins of the anterior tibial and the posterior tibial. And we can see on the right, we've now established brisk flow via anterior tibial and posterior tibial. We still had our wires up, and we can see we had some spasm distally in the anterior tibial. But when we actually took a posterior, a distal injection later, we had nice anterior flow. But we can see there's brisk flow now into this foot. This patient had complete relief of pain and has had total resolution of her symptoms, and now still has palpable pulses almost 6 months out. I think this case highlights what we can now do with guide wires, which historically we couldn't. This was a contralateral approach, distal lesions, total occlusion, and yet we still were able with certain wires to prolapse very tightly in a long infrapopliteal occlusion. And despite all of these bends that the wires were having to go through, once we changed to a Xi'an black, we're able to torque this wire easily through these various vessels, allowing us to cross these lesions and achieve limb salvage. So with that, I would like to invite our panelists for discussion. Let's start with Dr. Lasar. Dr. Lasar, what are your thoughts here on this case?
Well, first, Craig, congratulations, amazing case. I wanted to clarify one thing. When you went down through PT, through the loop, back up the AT, because there was a CTO proximally, and you actually crossed the lesion retrograde. Is that correct?
I did. Here was the problem. People had gotten subintimally there many times, and my wire early on, I'd first probed in that direction, and my wire wasn't going right. So I wanted to approach this from a different area, and I did cross that lesion with a wire. Once I had that in place, I knew exactly the path I needed, and I simply used my other wire to follow the path of that wire.
Yeah, clearly challenging. And ideally, when you run into a roadblock like that, going both directions is ideal. But I don't think you could have done it any better without that Xi'an black. I think that was the technology that really allowed you to move to that point and cross that. One additional option would have been just to is retrotibial access, and I have a case I'll show in a little bit, which is one way that you can do that. But clearly, in an affected foot, affected field, you want to avoid those additional distal punctures. A very, very nicely done case.
Thank you very much. Brett, any comments?
Yeah, I think it's this is a good example of having a wire for certain tasks. You know, you cross that long CTO with the Mongo ES, then switched over to the Xeon Black. And you know, the great thing about some of the attention that we're seeing to Guidewire technology is that it really kind of conquers that last mountain for us in terms of specific wires for specific tasks. So I think it's a great example and great demonstration of knowing what wire to use when.
Yeah, I can't emphasize enough how wires have changed. Now, I was lucky enough to be one of the original people doing coronary interventions when coronary interventions first started in America. And if we look at the guide wires that we started with, there's been tremendous progress made in these wires. They can give us better support, better steering. They can knuckle to allow us to cross. And my golly, things have changed dramatically. So, Dr. Lasar, I know that you also have a case presentation. Why don't we see your case, and then we'll discuss that after as well.
Okay, that sounds great. Thank you, Dr. Walker, and Asahi for the privilege to speak to you about the crossing is key, and Brett, always a great time to have you with us. And so I'm going to talk about as far as disclosures, most of the things that I say are my own, and Asahi does not want to have responsibility of what I say. But about 5 years ago, I started Vascular Institute of Chattanooga. It's a freestanding OBL, and our goal was to become a center of excellence for PAD and CLI. And as Dr. Walker and Brett, Dr. Weishman know, that's an unattainable goal to do that. But you fight for it, and that's what you try to do. So one of the questions we have with this particular case is, do we have enough perfusion to heal? And this is a 91-year-old female with a right foot surgery. It was a non-healing post-surgical wound times 6 weeks, and she presented with breast pain. She had a past history of PAD and CLI in both extremities, dyslipidemia, hypertension, non-smoker, palpable femoral pulse, and popliteal weak, but absent DP and PT pulses. And so the first thing we're going to do, at least as a vascular surgeon, is I want to do non-invasive testing. I want to see what's going on. We're going to get an ABI. It was 0.72, digital pressure 55. And when we look at the arterial duplex and we're looking at the lesions themselves, high-grade popliteal lesion, anterior tibial artery occlusion, PT is pretty much out. And so one of the things about critical limb is that ABI and digital pressures often don't correlate with the findings of the clinical findings. And that's what this case is also showing. So we often use pedal acceleration times to really look at the vessels within the foot and determine whether they have adequate perfusion. She did not. She had what we call class 3 perfusion, which is moderate to severe insufficiency, and that correlated with her clinical symptoms. Sometimes duplex imaging, ABI, and toe pressures don't do this. I think the PATs, just a quick discussion on this, where we look at the arteries within the foot and determine the actual flow characteristics in that foot. These slides have been a courtesy of Jill Somerset, who really kind of pioneered this in this country. But what we're looking for is the slope of the waveform in the foot arteries, and if it's fairly steep, it's very normal, normal flow, adequate perfusion. But if it's flattened out, then there's evidence of disturbed flow or proximal obstruction. And in this case, that would be consistent with critical ischemia. So we had some advances in technology, and this is one of the things that I've enjoyed working with over the last few years. Because of that technology, we often do ankle first approach in our lab and have completed over 1,000 cases with very low complication rates. But we started first with 4 French and 5 French sheaths, and then moved to 6 and 7 French sheaths to add the equipment that we needed. Generally, I start in a sitting position. I really want my hands down to my side, my elbows to my side, so we can get that distal access. You need to use a high megahertz probe. Hockey stick is common, and then we can gain access. And so we have intertibial access in this area here, followed by a small catheter. And this is the overview of the case. So we had micropuncture to start, 5 French sheath at the ankle, ultimately went to a 6 French antegrade approach, and we dealt with the SFA lesion, the AT occlusion, and the tibial perineal trunk stenosis. So this is our typical tibial access case, and see how fast that goes and beautiful that is. But unfortunately, that's not our case. So our case is really showing a single vessel outflow, tibial perineal or perineal outflow with the anterior communicator as really the sole flow into this patient's foot. So the question is, do we access the perineal? And occasionally I'll do that to protect that outflow. The sheath acts as a great reservoir to stop any type of embolization to the outflow. But in this case, we needed adequate flow and really reconstructing the anteriotibial. We started with the micropuncture catheter, and you can see the Asahi gladius. I was going into the anterior communicator there, but we're now kind of intubating the lesion and the CTO distally. And we're really kind of doing a push and rotation technique. And as we push that wire along, we also want to support that wire. So we switch out from the microcatheter to an 018 hydrophilic catheter to really add support to that. And so when we run into a lesion, as we kind of run into this little roadblock here, pushing that support catheter along really at least allows us to deal with this complete CTO of this anteriotibial artery. So it's that combination of wire and support that you need. When we ran into a tough roadblock here, so we stopped and we escalated the wire. And I tend to jump to the Gaia PV. It is a pre-shaped wire, and it will allow us to start to move along that subintimal space. And again, it's not a wire you can push. You can't, you'll deform it and break it if you just push it too hard. It really is a rotational type of process. And then as you start to rotate either clockwise or counterclockwise, you'll start to at least find those channels that allow you to move along. And in this particular case, we're rotating, a slight push forward, and now we're intubating the popliteal region. So at this point, we do need to access integrate. And so the goal is to go through and through from the ankle to the femoral level, and here's our catheter with the wire coming out. So that's our goal. How do we get there? Well, we use the 035 catheter above and get an image. We use the Asahi gladius wire to find a true lumen space, and with that in place, we can use the Gaia PV from below and try to reconnect through that proximal cap, as we did right here. And then as we move forward, the wire is now into the popliteal space, and really just rendezvous with the 035 catheter to get the wire through and through. So because it was subintimal, I did angioplasty, and we did use orbital atherectomy in this region. Post-angioplasty had a fairly good result with an adequate lumen. And then we want to check it. We have a direct connection. So we have fairly good perfusion there. Wasn't quite happy with how well that was, but I'm happy with that level of perfusion. And it also does embolization management. So if there's any debris, it will come out in that and really allow us to manage that. So the next step really is to get past this point and connect the circulation into the foot itself. And now we have a catheter, and we've advanced our wire into the distal AT dorsal pedal. We can remove the sheath, perform an angioplasty, and then this is our completion image here. So the question is, what do we do with the TP trunk? I'll be curious to hear from the panelists. Do we treat that? And in my mind, she's 91. I never want to have to operate on her again if I can avoid it. We know that if you have multi-vessel outflow, the perfusion, the flow seems to do well in bypasses as well as stents. So I do treat this in a critical limb situation. And so we did treat this with atherectomy angioplasty and had a good result there. And this is our completion. We have popliteal, AT, TP trunk, perineal, and we have now pretty good, robust flow into that foot. And so this is our completion of what we did, orbital atherectomy angioplasty, as well as over here, and then just angioplasting the inflow in-stent stenosis there. So as far as closure, we just use this a gauze to control any type of bleeding. We leave that on for 24 hours. Most people get to go in the outpatient lab home after about an hour to 2, and they leave with that on. And for the patients I'm very concerned about and want to know if their perfusion is adequate, we can do a post-operative acceleration time. And what we see in the deep plantar artery is retrograde flow, which is what you would expect from a dominant anterior tibial circulation flow. And you see the slope of this line is very vertical. And so it's 70 milliseconds. That's absolutely normal. We've gone from class 3 perfusion to class 1 perfusion, and she's expected to heal at that point, leaving the office. So no more amputation. That's one of our mottos here, and saving limbs and renewing lives in the Tennessee Valley. So I've enjoyed the opportunity to present and look forward to my colleagues' criticisms and comments.
Chris, that was a great case. Brett, what are your comments on this case? Any comments?
No criticisms really, Chris. You know, this is a scenario where you optimized flow through 2 different pathways there. And I think that there's a lot of conflicting data out there about multi-vessel intervention below the knee. I think the only thing I would say is here in a 91-year-old with a dorsal foot wound and you've reestablished flow through the AT, I probably would not have elected to treat the TP trunk there. But if you can treat that successfully, to your point before, the more vessels you have, the better, at least in theory. But I think you certainly, you treated the area of interest specifically. And if you can do more than 1 vessel without adding morbidity to the procedure, then I think that it's totally reasonable.
Yeah, Chris, I think this is a great case. You know, I'm amazed by how opinions have changed. In the very earliest days of pedal angioplasty, I submitted a series of cases, which was almost as large as the world's experience, to Journal of Endovascular Therapy, and got back a scathing letter. We not only won't publish this, but we think this is crazy that anyone would stick a pedal vessel, and now how that has changed. I actually liked your approach, and I agree with working on this perineal, and I'll tell you why. If we look at radial arteries are similar size to pedal vessels. If we look at radial intervention, we lose some radial vessels over time. We're sticking a vessel, there's a risk of obstruction. And certainly, I think in critical ischemia, sticking the vessel is worthwhile, but we do have to keep that in mind. And so, you know, you fix the perineal as well, which I think gives you a little extra insurance here. I agree with you. I think that the pedal sheath also serves as a filter, if you would. There is one thing I think that's important that we really can't do as well from a pedal approach, and that is go into the foot if there's disease in those branch vessels of the foot, because we're really kind of stuck in the other direction. But I think pedal approach has really changed the entire complexion of limb salvage, and has, I think it, along with the new wires and crossing catheters, allow us to cross the overwhelming majority of lesions. And that's really important because we can't treat until we cross. And so I think you did a great job on this case. And certainly this lady was lucky to have you there for her.
Oh, thank you, Craig. I think, you know, some experience with the primary tibial approach. We've had about 1,000 cases that we've completed, and about 25% of the time we're going to be dual, antegrade and retrograde. And I think that's kind of be expected. But you know, a lot of these patients are fairly ill, and we do a lot of this work in an outpatient environment. And so throughput is important for the unit, but also safety for the patients. And if we can avoid a large vessel access, the risk of bleeding is almost zero, and unless you perf or cause a problem, you know, with the procedure. But the access complications that we've had are less than 1%, even though half the time in those 1,000 cases it's 6 French and the other half is 7 French. And so we can use the proper device that we need for the lesion that we're dealing with, but the access is, I think, is a safety factor for outpatient environment. But Craig, I have a question for you because, from a vascular standpoint, when I first started all this, we would use an 035 wire and we'd knuckle that wire and we'd get across the CTO, and this was 20 years ago, and then we'd balloon a little bit and be so excited that we had a subintimal angioplasty. And I've fallen down into really that more 018 category of wire. But you, from a cardiology standpoint, really are focused in that 014 wires and some of the nuances of those wires. I liked your case because I saw such variability with those wires where I don't necessarily always see that with the 018s. But do you have some experience on the 018 wires as well? And can you comment about the two different platforms?
Yeah, I use 018 wires a lot. 018 wires, if we look at torqueability and support, it's really related to the fourth power of the radius of a vessel. So albeit 018 doesn't sound like much bigger than 014, it does have better torque and it does, typically, and it does have, assuming the same construct, and it does have greater support, about 2.7 times to 2.73, I think, as I did the math in the past. But I routinely use, when I'm doing a pedal approach in 18,000 wire, I do that for more than one reason. I do that because it does give me good torque, but it also gives me better support to get my sheaths in, particularly in densely calcified vessels. In these cases, the 014 wires just doesn't have enough oomph to get me across the skin, which is often thick in this case, and into the vessel. So I do start with 018 wires when I'm doing pedal approach. Now, sometimes once I'm in, I may go to a wire such as a Mongo ES if I'm unable to steer and I want to make a very, very tight loop. The Gladius also makes a very nice loop as well, but I think not quite as tight as the Mongo ES. But I like both of those wires, use them a lot. I will tell you, I use probably equivalent numbers of Gladius 18 and Mongo ESs, similar numbers. I like the Gladius 18 better than I like the Gladius 14. It has a shorter amount of hydrophilic tip. I like to lase a lot as my atherectomy tool, and you never want to lase over hydrophilic section. Both the Mongo ES 14,000s and the Gladius 18,000s have very short hydrophilic sections, so you're not worried about disrupting that hydrophilic segment.
Perfect. Thank you.
Okay, well, Dr. Wickman, I understand you have a case as well that you'd like to show. Can you show us that case?
Okay, so we're getting a little bit of different flavor from cardiology, vascular surgery, now from interventional radiology. I want to thank Asahi and thank Craig and Chris for joining me here on the panel. I'm going to present a case of an 82-year-old female whose foot is pictured here, and you can see that she's got profound left forefoot ischemia. She's had, like many of these patients, multiple previous interventions, bilateral iliac artery angioplasty and stenting, a previous left popliteal stent across the knee joint, actually into the below knee popliteal segment. And here's her angiogram. Everything above this is patent, flowing well, but her primary problem, as you can see here, is tibial disease, quite severe diffuse tibial disease, tight lesion at the origin of the anterior tibial artery, and diffuse disease. And you might think that this is the dorsalis pedis, but I can tell you that on selective angiography, this did not turn out to be the dorsalis pedis. It's actually just a collateral that's kind of simulating that path. She's got tibioperineal disease. She has tight, basically a subtotal occlusion of the origin of the perineal artery and a diffuse long segment posterior tibial artery CTO. And you can see some opacification, albeit faintly, of the medial lateral plantar vessels. So our approach in this is typically, as has been shown by Chris and Craig, we choose to initially start with an antegrade approach. I think that there are some certainly valid reasons to use a pedal first approach in some cases. I'll make the point today or tonight, perhaps, that with the Guidewire technology that we have available to us, that we're actually using pedal access less. And I think we have the ability to cross some of these longer lesions from an antegrade approach. you can see on the left panel here the end of that popliteal artery stent, which comes down right to the origin of the anterior tubule. And we were successfully able to recanalize the proximal perineal artery occlusion and balloon it, as you see here. And then this is us getting into that occluded posterior tibial artery occlusion using a support catheter and the Mongo ES wire here, to the extent that we were able to balloon that long segment posterior tibial artery occlusion. You can see we left a guide wire in place in the perineal artery here as well. And here's our final angiogram here. You can see good flow through that posterior tibule and into the perineal artery, although it's still very diffusely diseased, and good opacification into some of the plantar branches, although they're very diffusely diseased. And you can see that that anterior tibial artery does ultimately occlude, and this is not the dorsalis pedis here across the ankle. Nonetheless, this is her baseline image, and this is 1 week post-intervention. So you can see the appearance of the foot is markedly improved, and she has a palpable posterior tibial artery pulse at the end of the procedure. That's one of our endpoints that we use on the table. So I want to take just a minute and talk a little bit about Guidewire technology, because it's often overlooked or not considered as much. And to Craig's point earlier, the technology that we do have has come a long way and has been adapted somewhat from the coronary world. So when we're talking about CTOs, we're almost always talking at some point about prolapsing the tip, whether that's to be in the subintimal space. And prolapsing the tip or creating a loop can be a good thing. It can be your friend, but there are some problems that come with that. And usually what happens when the tip is prolapsing is because the tip of the wire is being trapped either within the subintimal space or within a lesion. And then as you advance the wire, the potential for disaster is real. So if you damage the tip, you may have trouble advancing it or certainly torquing it and steering it. So ideally what you want to do is be able to minimize the length of the prolapse or the loop and the diameter to be able to maintain that ability to advance and control the wire. And I think some things in the case that I showed here of that long CTO, and I believe that Craig showed this as well, is some characteristics of the Mongo and Mongo ES wire. The things that I take into account when I'm considering what wires to use are basically 3 things here. The durability, in other words, is it going to last for the intervention? The crossing, the potential intervention, am I going to have to pull 2 or 3 wires off the shelf? The hydrophilic nature of the wire when we're dealing with long CTOs, with the lubricity. And then, of course, the ability to torque. And some of the features of the Mongo and Mongo ES, I think, are worth spending a little bit of time on to highlight why I like this wire. First of all, these are 014 wires, and that's to Chris's point before about 018 versus 014. Everything in the foot for me is 014, certainly for accessing retrograde in a pedal artery. I like the 018 for support and pushability. But in terms of these wires and using for intervention into the below knee segment and below the ankle, I think the features here with the polymer jacket and the hydrophilic coating speak to the lubricity of this technology. It's got the outer PTFE coating. Different lengths of that coating, of course, on the Mongo 41 centimeters versus 10 centimeters on the Mongo ES, which has a little bit more support. They all have the polymer jacket and they have the Act 1 technology, which is basically kind of creating this extra support and some durability. So it kind of meets this architecture of the wire, if you will, meets all the 3 things that are important for my considerations when choosing guide wires. Let's look at some of these specifically. If you look at flexibility and the load versus the distance from the tip within the first 3 centimeters from the tip, you can see that the performance here of the Mongo and the Mongo ES is superior to some of the more some of the different wires that we use, again, for different indications. I made the point before with Craig's case that there are different wires for different occasions, if you will. And the fact that this has the durability that I'm looking for, it has to do with this distal core that helps reduce the amount of tip deflection, minimizes the prolapse, and therefore eliminates the kinking and sometimes even fracture that occurs in the tip that I'm sure we've all experienced. Lubricity, again, excellent lubricity here due to the hydrophilic tip and the polymer jacket, and it allows you to pass smoothly through these lesions. I think hydrophilic wires are certainly favorable when we're dealing with some of these long CTOs as well. Craig mentioned the ability to torque here, and again, it's related to this kind of multi-wire technology that they call the Act 1 technology internally with Asahi, and provides that better torque ability. We've all been in those situations where we've got so much torque built up in the system that at a certain point it just whips around like it's a helicopter. So this graph kind of depicts the ideal situation with a 1-to-1 ratio, but there are certainly technologies that are more favorable in terms of its ultimate torque response. So in summary, with this particular wire, I think it has excellent durability. If you need a loop made or you need the wire to prolapse, it will do that, and it's very sturdy. The hydrophilic nature is an advantage for sure, and it really does provide an excellent torqueability system due to the wire construction. I'm going to show you one other companion case here. This is a 77-year-old male with insulin-dependent diabetes and hypertension. Was ambulatory and then was admitted into a nursing facility and was known to have a poorly healing left foot wound. Here you can see on kind of the lateral aspect of the plantar surface, kind of by the 5th metatarsal head. This is his arteriogram. You can see kind of a similar, somewhat similar anatomy with a long posterior tibial artery occlusion. As my last case here, anterior tibial artery is occluded proximally and a patent perineal, which reconstitutes through some collaterals. And then you can see on the last panel here, we're actually seeing some of the plantar arch vessels. Here's crossing again with a support catheter and a Mongo ES and a Rubicon support. Once I get through that long posterior tibial artery occlusion, I like to switch out using a regalia wire. I think it's one of the most trackable and torqueable wire through the pedal loop. If I have to go through the pedal loop, we can debate about the utility of the pedal loop in a situation like this, but I was really using this for making sure I got adequate access into that lateral plantar. This is actually using the Phoenix atherectomy system followed by angioplasty all the way into the plantar branches here. And then if the video is playing here, you can see nice brisk flow all the way down into the medial lateral branches now that we've reestablished flow through the posterior tibial artery. And here's his wound about 2 weeks post-intervention. You can see a little bit, the eschar is gone. There's a little more granulation tissue. And then at 4 weeks, he's starting to be well on the way to wound healing. So a quick summary, I think these patients are challenging to treat. We've all shown cases here this evening with long lesions, a lot of calcium, frequent CTOs, as well as multiple comorbidities. Lesion crossing, to Craig's point earlier, you can't treat unless you cross. And so the ability to cross with the technology that we have now available to us leads to procedural success. And historically, the peripheral guide wire space has been somewhat overlooked. And I think that the platform that Asahi offers is performing well, and it matches some of these challenging lesions that we have to treat, including CTOs, and then the other end of the spectrum with negotiating through the pedal loop.
Great cases, Brett. Dr. Lasar, any comments at this point?
No, I think that Brett, again, awesome cases. Again, one of the things when I have patients that you've shown with a Rutherford 4 or 5 and 6, I often will go antegrade as well. Usually antegrade SFA if they have a nice vessel or a common femoral. And one of the concepts I try to drive through to some of the docs I teach is if you can stay axial to the lesions, you have better chance of crossing. To do the crossing that Craig did with his first case is extremely difficult because of the distance and the torqueability. But for the less experienced doctors, you want to be successful. And so to be successful, I think you need to get close to the lesion if you can, and then use the wire technology, as Brett, you described it so well, to get across that section. But I think it's, again, great cases. And I think that both approaches, antegrade, retrograde, are sometimes needed to actually be successful, to win for our patients. And so it's nice to have both of those capabilities.
Sure, certainly access is crucial as well. It's one of the keys of success, but so much has changed. In terms of, I was mentioning the difference in wires. If we take a Xi'an black wire, it is a 14 thousandths wire. And within that 14 thousandths format, there are actually 15 wires. There's a core wire. There's the coil, that's 2 wires. There's a twist wire, that's 7 wires. And then there is Act 1 technology, which is a twist of 6 wires, all within a 14,000s format. And you might imagine how this changes things. They've also taken the inner core, which typically going to the tip of older wires was flat, and they made it round. That helps to get rid of whip. By adding a twist wire, it gives us much better torque. So what's happened here is really dramatic. You know, towards the point that Brett made, when we prolapse a wire, it's very important that we watch the entire prolapsed area. If the prolapse keeps growing and growing, the loop in your wire, and it keeps widening, you're quite apt to be enlarging a dissection somewhere. And some of these newer wires allow us to control just how big an area of prolapse we have, and that may indeed help us. There are whole new ways too in terms of access. Accessing totally occluded vessels is now part and parcel of limb salvage. Accessing through occluded stents when we can't get in from another angle, the wires going around. So access is important, but again, these wires are helping pave the way because these wires allow us, once we're in, to cross and then to introduce sheaths. And I think it's paramount that physicians study wires, learn the construct, and understand what are the differences. Some wires we want to use for crossing a lesion, some for delivering a tool if there's dense calcium, some to not injure distal vessels if we can't watch them. And I think it's crucial that every interventionist acquaints himself with the therapeutic armamentarium of wires that are available if one is going to have best crossing success. These were all great cases. These are cases that in many places people say are untreatable cases. And you saw these were cases that were crossed actually fairly easily and with great outcomes and with limb salvage in these cases. But I think understanding guidewire technology is important. And I think we certainly have to devote a lot of our time to understanding how wires work, how they're different, and making sure that we use the right wire for the situation.
Yeah, no doubt, Craig. I remember we've all sat on different advisory boards for different companies, and if you go to the stent table or the drug-coated balloon table and go to their panel and everybody's eyes light up, and for a long time, somebody goes to a Guidewire session and you can see the eyes kind of roll back in their head. People are kind of bored with the idea, but it really is such a critical part of the case because as we said before, if you can't cross something, if you can't get to something, that's part of it, right? Access is key. If you can't cross it, you can't deliver therapy. And so I share your opinion that learning the different technical aspects of each Guidewire helps you decide what to use for what particular situation.
Yeah. You know, modern day
closing comments.
Modern day limb salvage, the people who do this all the time and they love to do it, you become very passionate about it and you want to win, and you want to win because your patients are so deserving of it. And most people are in that 95 to 96% range of limb salvage if you do this day in, day out. And understanding the tools that are available are critical to your success. If you can't access, you can't cross, and you can't treat properly, you won't be successful. And so, but the wire is the scalpel that we use now to guide our therapy, and from a surgical perspective. But this technology really allows us to win for our patients. And so I thank you for allowing us to discuss these cases and talk about this.
You know, one other point that I'd like to make is I view a Guidewire as part of the tool. I view the support catheter we use with that as also quite important. It imparts so many other things in terms of crossing. It gives us better pushability. It allows us to often straighten out the wire if we need to. It gives a greater tip penetrance if we get close to the lesion. And so I think that the changes that have occurred in crossing technology with wires, both the wires themselves, as well as the support catheters that come with them, have really made limb salvage so much more successful in today's world. And I can't emphasize enough. I think we need to concentrate really hard on learning wires and making sure that we use the right wire, the right crossing tool, the right access on the right patient to achieve things. And I think that this is something very much in evolution. Not only are the devices changing, but the whole techniques are changing. The techniques of actually accessing totally occluded vessels. This is something unheard of in the past, but certainly is becoming more and more commonplace in limb salvage.
Yeah, no doubt.
Absolutely.
Well, guys, with that, perhaps we'll wrap up this session. Once again, I would like to thank, on behalf of all of us, Asahi, for your continuing devotion to medical education and for what you've done in terms of giving us tools that allow us to treat our patients more effectively. I thank all of you for watching this program.
Thank you.
Thank you, Craig.